Okay, thank you very much for your nice introduction. Okay, we are ready to start our last webinar about orthodontic treatment of malocclusion with dysfunction of the craniomandibular system, or another word, the dysfunction of temporomandibular joint using gunmetal arch wire. Um, this is a very important subject because we have too many, especially too many children who start with some problem in the TMG, a very early stage of growth and development. So it's very important to take care of this kind of patient. Okay. Um, but first of all, what is the TMD? What is temporomandibular disorder? What it does it mean? Um, Maybe almost 40 years ago, this guy from United States, Dr. William Parra, he described new uh, new problem at the joint. Yeah, he said in that time that sometimes some people got problem between the condyle and the disc, and he called that problem internal derangement. And he described or he reported by two papers, one in 1978, another in 1999, 1979, about the internal derangement between the condyle and the disc. It was almost 40 years ago. Um, he he was oral surgery. He did so many open surgery at the joint and also some arthrography. He checked the relationship of the joint between the condyle and the disc. Sometimes the condyle is displacement and also the disc is displacement. So we have a problem at the joint in many patients. Mm, in one of his paper, he described the temporomandibular joint inferior joint space by arthroscopy of the derangement of the disc and the condyle. For example, this is a normal situation. He said that in that time here the condyle and the disc have a good relationship, are in centric relation. Okay, no problem. But some patients have some early opening click. In this patient, the relationship between the condyle and the disc is not centric relation. The disc is a little bit forward position, anterior displacement, and then in the excursion movement, and the condyle reduce the disc, but finally, after the incursion, again the condyle is displaced and the disc is in the anterior position. Also, this intermediate opening clicking, same situation, and some people show this late opening clicking, and finally, is this problem progress, and the people can develop a complete anterior dislocation of the disc. Okay, finally the patient have some lock joint and something like that. Yeah, more than 40 years ago, Dr. Farah described this type of problem, but still in the traditional orthodontic, um, nobody pay attention at this type of problem. Yeah, and nobody can take care of this patient with internal derangement of the temporomandibular joint, disc and condyle. Also, he described as something like this, the reciprocal clip. Initially, the relation between condyle disc is not good. After that, some reduction of the disc, but finally, again, the condyle is lost by the disc. Okay. Um, Also, he describes some symptoms accompanying with internal derangement, especially autonomic nervous system symptom, like a pain, another symptom like a ear symptom. Um, if this symptom progress, this patient can finally go to the internal or degenerated arthritis and also temporalis hypertrophy, and also he reports some problem, especially spine scoliosis. Yeah, some symptoms like this. Um, Also, he report about the course of the internal derangement. Um, he said that frequently the first early sign of the internal derangement is posterior capsulitis. This is characterized by edema in the retrodiscal path. Usually, the sequence are capsulitis, then the, the patient start with some clicking. After that, some patients develop acute lock, then chronic lock, and finally osteoarthritis of the joint. So, in these patients, usually they have general problem associated with temporomandibular disorder. Usually, they show posterior discrepancy because a lot of overreaction. This overreaction produce some posterior interferences and displays the mandible. Yeah, so it's very important in order for to treat this patient to eliminate posterior discrepancy, to get some space from the uprighting alternate vision. Um, Maybe also you have to eliminate one of the etiological factor of that is producing this kind of problem. Also, if the mandible is displayed from the physiological position, this displacement position of the mandible is a deranged reference position. This is not physiological position. This is the reason because in all the patients with problem or at the joint, we have to establish a new position. We call this new position THP position, therapeutic position. Okay? And this new position we have to establish taking in consideration the vertical dimension and the occlusal plane control. Okay? Yeah, because the occlusal plane inclination is very nice correlated with the skeletal anterior posterior position of the mandible, and especially with when this posterior occlusal plane is very steep, induce a lot of interferences in the posterior part of the dentition, and in because of this interference, it's not possible for the mandible adapt to the forward position. So it's very important at the earliest stage of treatment, elimination of the posterior interferences in the patient with temporomandibular disorder. Also, it's very important to considering in these patients the occlusion support. Usually, in these patients, they show loss of occlusal support. It means overloading of the joint, okay? And then a lot of compression, a lot of symptoms. We also, all the dentition show very mesial inclination of the buccal segment. So it's very important to abride all the dentition in order to establish a new occlusal support. Also, these patients show problem in the arch dimension, especially in the upper arch, in the premolar area, show a very negative curve of Wilson. So we need to enlarge all the upper arch in order to make a very nice coordination with the lower arch. Okay? After that, we have to control the occlusal diagram, special premolar guidance, try to establish this sequential guidance, yeah, from the canine to the posterior teeth. All this guidance must be a little bit open, open, open. Never leave this guidance with a very steep inclination, because the mandible cannot adapt in a good condition to the transversally, and also no anterior adaptation. The mandible is possible when all the guidance are very steep inclination. Okay. Also, another point that we have to consider in the temporomandibular disorder patient is the occlusal support. Usually, when the patient has very nice occlusal support, or all the biting force are distributed throughout the maxillofacial skeletal frame, and in this way, the mandible is very nice. All the occlusions are very harmonized with the craniomandibular system. But what happens when the patient lost occlusal support? Occlusal support means that the mandible couldn't be in the anterior position and easily goes back and makes a lot of compression. The cause of this, of the loss of occlusal support, could be when the patient lost the first molar, yeah, easily loss of occlusal support, and when the posterior occlusal plane is very steep, it's not good for the occlusal support. For this reason, it's very important to establish very nice occlusal support. If the patient lost occlusal support, the biting force are too much concentrated on the TM joint, and when occlusal support is lost, yeah, especially in this area, and this induce a compression force at the joint. So this is the reason, because it's very important in the early phase of the treatment of our orthodontic treatment using gold medal, to put especially in the lower arch very strong tip bend in order to upright all the dentition. The effect of the uprighting are increased vertical dimension and establish new occlusal support, also make space making for the correction of the anterior discrepancy, of course, unloading the joint. This is very important. them to get a stable occlusion in order to, to maintain the anterior position of the mandible. But in orthodontic treatment, especially in this type of patient with problem on the joint, who is most important? Premolar extraction or first molar extraction? Yeah, of course. Our Sato concept, yeah, Professor always advise to eliminate first molar in order to try to upright all the dentition, move all the dentition at same time using pivot bend, and then you can eliminate the anterior discrepancy, correct measure inclination of the dentition, and establish new support. Yeah, please never extract first premolar. Yeah, because you lost a lot of occlusal support. Okay, this is not good in the patient who have problem at the joint. General consideration of fundamental orthodontic treatment objective of malocclusion with TMD. Avoiding premolar extraction when the malocclusion indicates a tendency or loss of posterior occlusal support. It's same as compression. The buccal teeth must be upright and parallel to the occlusal force to accept these forces without collapse lingually, anteriorly, and vertically. Yeah, the mandible have to be free. Functional freedom for all the excursions, anterior excursion and lateral excursion. To accomplish the above, second and third molar extraction, of course, is recommended. Major purpose for orthodontic reconstruction of occlusion with TM joint dysfunction are the first and the most important, reposition the mandible in a physiological position. It means anterior position. Yeah, is the patient can do some function like a grinding and clenching in this anterior position is very good for the health of the patient. Okay, and then stabilization of the posterior occlusal support by uprighting all the dentition, and then try to get proper occlusal guidance system. Also, it's because of this, for this reason, it's very important the relationship between the occlusion and the temporomandibular disorder. Yeah. Also, orthodontic and occlusion is very close relationship. Yeah, a long time ago, Dr. Edward Angle, considered the father of this specialty, he introduced the term malocclusion to the dental profession as any abnormality in the dental configuration. In 1972, Dr. Andrews proposed this basic keys to establishing a sound class 1 occlusion. This became well accepted orthodontic treatment guidelines, but unfortunately, there was no reference to the patient's joint position. Yeah, nobody take care of this. The patient with problem at the joint. But in the middle of the 1970s and the early 1980s, some orthodontists began to consider the importance of developing a sound of occlusal position at the same time that the condyle were in a stable joint position. For this reason, sometimes the literature shows that there are at least five major etiological factors that can be associated with temporomandibular disorder. They are occlusion, trauma, emotional stress, deep pain input, and of course, parafunction. And since occlusal factor may be a potential source of TMD in some patients, it will be seems logical that orthodontists should develop occlusal conditions that will minimize any risk factor that may be associated with TMD problem. A lack of harmony between the occlusal condition and the joint position may be a risk factor that potentially dysfunction of the structure. So it's very important for the orthodontic must be or must always be aware of the musculoskeletally stable position of the condyle and finalize the occlusion in the relationship of this position. In another word, the orthodontist must provide an occlusal condition that is within the patient's physiological tolerance of or adaptability. This is very important. Okay, it's being anterior position, and this anterior position must be keeping by the occlusion. It's very nice occlusion so far. But what happened right now in our orthodontic field? In recent years, TMDs with severe degenerative change is the most critical issue in dental occlusion due to its early onset. It means some juvenile people associated physical symptoms, difficulty in treatment, and especially decrease in quality of life, a very early stage. Mm. So, many malocclusion associated with degenerated temporomandibular joint disease are characterized by uh, onset. Usually, this early onset problem start in late stage of mid dentition, especially in class 2 malocclusion. Also, it's characterized because increase the horizontal condylar angle and finally develop osteoarthritis change at the joint. Also affecting the functional movement of the mandible, especially in the working side of the mandible. So it's very important understanding the relationship between occlusio and TM joint in daily clinical practice, and now to apply it to occlusal treatment is the basis of diagnostic and treatment planning. This is important because too many juvenile patients show degenerating TM joint disease, especially early onset of this problem. And usually we have patients, especially class 2 high angle patients, very juvenile state. For example, this 19 years old female, class 2, open bite, chief complaint, crooked teeth, small chin, master problem, too much retronative mandible, very stiff posterior occlusal plane, a lot of interferences in the posterior part, and you can see the condyle, a lot of flattening this condyle, a very early stage of growth and development. And you can see flattening in this 3D flattening condyle. Um, in this MRI, the condyle is displaced posteriorly in the closed position. The condyle is posteriorly positioned and this is anterior position. When she open, she reduce the condyle, reduce the disc. Okay. Also, this is another patient, uh, teen years old female, class 2, open by, high angle type, post joint pain, and you can see her condyle, a lot of flattening. Condyle are very small and backward positions. And the mandible is open, and posterior occlusal plane very stiff. This is another case, 19 female patient, again, open by, class 2, jaw in noise, flattening, very severe flattening of the condyle. You can see almost nothing. And this is the MRI. You can see that the condyle in this disease, the condyle position is posterior displacement, okay? And the disc is a little bit forward. So, especially the class 2 high angle case is a case, is a patient that is very susceptible to develop TM joint dysfunction problem. Why they are very susceptible to develop TMD problem? Because the mandible is too much retrognathing mandible. By the why retrognathing mandible? Yeah, because posterior occlusal plane is very stiff. POP is very stiff. This posterior occlusal plane induce a lot of posterior interferences, so the mandible cannot go forward position because a lot of interferences in the posterior part of the dentition. Also no reduced control in the premolar area because no contact. And you can see all these patients, they have shown you no reduced guidance here in the premolar. Also this one, no reduced guidance. You have to get very nice reduced guidance, upright all the dentition in order to reposition the mandible forward. This is a very big problem in this type of patient, this type of malocclusion, class 2 high angle. Yeah, because a lot of interferences, posterior occlusal plane inclination is very stiff and no reduced guidance in the anterior part of the dentition. Okay, this is the causes because the mandible is too much retrognathing position. So usually in these high angle cases, we have this type of problem: stiff POP, no reducing control in the premolar, reducing guide mandible, compression of the condyle. Yeah, this compression induce a degenerated change at the condyle. Of course, molar interferences because posterior occlusal plane is very stiff. So how can we correct this type of problem? Yeah, the first we have to do is to eliminate posterior discrepancy in order to upright all the dentition. We have to get some room in the posterior part of the dentition for uprighting. This uprighting process increase vertical dimension, establish new occlusal support, and the mandible can adapt forward because no interferences in the posterior part of the dentition. In order to establish anterior position the mandible, it's very important to get in the premolar area reduced guidance, okay, reducing control, and then mandible can adapt forward. Also, it's very important in very early stage of treatment, enlargement the upper arch. This is very important, and then try to coordinate upper and lower joint, okay? Upper and lower dentitions, okay? And then all these movement, the mandible can adapt forward and then unloading the joint. Okay, we start leveling and then upright buccal segment. Not only antero-posterior are uprighting, also transversal uprighting is important. It's essential in order to treat this type of patients. Then tip a bend in order to flattening posterior occlusal plane. At first, you have to flattening first the lower posterior occlusal plane, and then you can make some extrusion in the upper and second molar, and then flattening upper posterior occlusal plane. After that, the mandible position change due to posterior interferences. When you eliminate posterior interferences, the mandible immediately change the position. This anterior change of the mandible position induces to the unloading the joint. And then you have to control this anterior position of the mandible by the first premolar retrusive guidance. Okay? After that, the mandible further reposition forward and become class 1. And finally, you decompress the joint, unload the joint, and then we can correct this dysfunction problem in this way. But why early onset of this type of problem? Especially in some children start developing this type of problem in the first functional period of changing dentition or in the second functional period of changing dentition. This is the reason because Professor Sato called this problem 10 years old syndrome. Especially because during growth and development of facial occlusion around 10 years old, not exactly 10 years old, it's between 9 and 12 years old. And these are critical age for developing internal derangement of temporomandibular joint. And Professor Sato's clinical observation showed that many young patients around 10 years old, or 9 or 12 years old, have already started this functional problem. So it's very important to intercept this type of problem. And the way you can prevent or intercept this type of problem is reposition the mandible forward. Reposition the mandible to the physiological position. Okay? Our treatment is a treatment of the reposition or mandibular reposition treatment. So, from orthodontic point of view, early detection and treatment approach to PMD and malocclusion is important for providing the healthy function of masticatory organ, because the dynamic function of the masticatory organ connect with another part of the body like autonomic nervous system. Okay, in order to prevent dysfunction of the autonomic nervous system, we have to change mandibular position. Why 10 years old syndrome? Yeah, because 10 years old are the final stage of completion of occlusion, final stage of TMG, craniomandibular system development, the most important stage for harmonizing TMG and occlusion and establish physiological mandibular position. Okay? In this phase of development of the occlusion, mandibular positions are changing because because the erection of the teeth, and the vertical dimension change, and the mandible position change, because the mandible is always looking for the low vertical dimension, okay, part of the tissue. So this is the reason because the mandibular position is very unstable in this phase of treatment or of development. And also is the time that when the second molar erection, also third molar growing like this, especially in the upper arch, in the posterior tuberosity. At this age, the third molar start moving and want to go to the into direction, and this movement induce a pushing, squishing out effect of all the dentition, and the vertical dimension increase so much. Okay, Professor Sato called this lack of space in the posterior area, in the molar area of the dentition posterior discrepancy. This over-reduction of the posterior teeth induced to the molar interferences, and also change mandibular position, and finally increase so much posterior vertical dimension. Okay, and also change occlusal plane inclination. Um, some paper like this from Mogi report this functional problem of the temporomandibular joint, especially in the very early stage of growth or development. For example, in this study, at 12 years old, start some problem like increasing joint noise pain, noise treatment, and something like that. Yeah. Very early stage. Okay. Also, Professor Sato, Fujima, they did some research, and the Professor Sato Orthodontic Department at the Kanagawa Dental University, they check no general population, just only orthodontic patients according with age. And also these data show that early onset of this temporomandibular disorder symptom, especially from 9 years old, 11 years old, and from 12 and 14 years old, increase the prevalence of TMD symptoms at the joint. Okay? By why? Oh, Professor Sato also asked this question: why TMG shows the early onset of internal derangement compared with another joint of our body, like knee joint? For example, in knee joint is a very, we have a lot of joint in our body, maybe 262 joint. Um, for example, the knee joint also receive a lot of strong forces, a lot of loading, but usually our knee joint is very safe. Yeah. Some people with overweight can develop some internal derangement at the knee joint, but usually over 60 years old, yeah, people start developing some problem at the joint, but the joint is very safe. Why our joint, our temporomandibular joint, onset this problem at very early stage? This is a very nice question. Okay, and this is another paper from Tanaka. He checked different malocclusion like open bite, class 2, crowding, hip bite, class 3, posterior cross bite, and in any type of malocclusion, yeah, can develop, especially in the middle school, the prevalence of symptomatic symptom at the temporomandibular joint. Okay, especially at this age, from 9 to 12 years old, onset this type of problem. Okay, but why our temporomandibular is very susceptible to develop this problem? Yeah, the reason is because our temporomandibular joint has a very unique morphology of the condyle. Yeah. Our temporomandibular joint differs from another joint because it's covered by a layer of fibrocartil instead hyaline cartil. And the bone of the mandibular condyle is located just beneath the fibrocartil, making it particularly vulnerable to inflammatory damage and vulnerable model for starting arthritis and bony change. This is the reason because we human beings develop very easy problem at the joint, especially in very early stage, very young people like the 13 female patient with severe temporomandibular joint pain. It's a class 2 retronative mandible patient. You can see class 2 relationship, increase over yet, and is you check posterior part of the dentition, posterior occlusal plane inclination is very steep. It says a high angle class 2 case with very retronative mandible, posterior backward rotation of the mandible, a lot of compression here, and very small condyle also, and a lot of flattening at the condyle, a very early stage. This is another patient. My patient is Christina, 16 female patient with severe right temporomandibular joint pain here, almost acute lock in the right joint. And this is her occlusion. Yeah, usually the class 1 thinker used to think that everything is okay when the patient is a dental class 1, but this is not true. For example, this patient is a class 1 relationship, but have a lot of problems. You can see the guidance, especially this canine, upper right canine is very stiff. Also, anterior incisor is too much retracted backward. Okay, and this patient, she doesn't have anterior opening angle here or anterior function of the mandible. This twisted inclination of the anterior dentition induce a posterior displacement of the mandible. This is a 3D CBCT. All the guidance are very stiff guidance, and the condyle very back, the backward position, and posterior occlusal plane, especially in the right side, is very stiff. Okay, and this is the waist, and you can see here no anterior opening angle here. And skeletally, for example, here the interincisal angle is very high value. It means that all the anterior dentition is retro inclination, upper and lower. Okay, anterior face high. So okay, skeletally is dental is class 1, but skeletal is class 2. Yeah, but a lot of retro inclined anterior incisor. For Professor Sato, this retro inclination of the anterior teeth induce anterior interferences. Yeah, and these upper front teeth interfere with the free movement of the mandible, and this causes mandible backward displacement. Okay, this is the reason because this is a cause of malocclusion. Okay, so we must eliminate. We have to open the veins in the anterior part of the dentition in order to reposition the mandible forward. Okay. Um, Percondyle position. This is a frontal view of the condyle, axial view, sagittal view, position, backward position. Especially posterior occlusal plane is very stiff in the right side. This induces a posterior displacement of the mandible. Also, left side posterior occlusal plane is stiff, inducing also posterior displacement of the mandible. Okay. You can see here no space here, no inter opening angle, and the mandible move backward position. And you can see her condyle, right condyle, back position, backward position, and also is displaced a little bit medially. Okay, right side, left side also same problem. This is a coronal view, okay, same position, and I check in this patient, and this is a horizontal condylar angle. Usually, I used to measure this angle from the longitudinal uh, axis of the condyle from lateral to medial pole and to the coronal reference plane that goes to sella perpendicular to mid-sagittal reference plane. Okay? In this case, it was not too high, and this is an MRI of this patient. This is the position of the condyle with a close position, and you can see in close position the condyle is in backward position, and here the disc is anterior position. And when G open, this is right side, the condyle couldn't reduce the disc. Okay, this is a anterior displacement of the condyle of the disc. Sorry, of the disc without reduction. Okay, in the right side, and in the left side, this is a closed position. The condyle is here, and the disc is in the anterior position. But when G open, the condyle reduce the disc. Okay, so it's anterior displacement of the disc with reduction in this case. So we have to treat this type of patient, okay, as soon as possible. Yeah, and this is the reason because it's very important to increase vertical dimension and to establish new occlusal support. And in the growth, normal growth process, the task of the occlusion is during growth period is increase vertical dimension, especially at the 6 years old. In this way, the mandible rotate forward to adapt to the continuously increasing vertical occlusal height. And then this provides very nice environment at the condyle, and then the condyle grows secondarily. Okay, this is the normal growth process. We have to imitate the nature. Yeah, in our treatment, especially in class 2 treatment with this function problem. Okay, this is very important. Um, and again, this is probably the mechanism of occlusal support. How the human get the occlusal support, because in the early stage, the, the vertical dimension start increasing because of the tooth erection, and then provide anterior rotation by adaptation of the mandible, and this provide unloading the mandibular condyle. Okay, this is occlusal support. Yeah? Occlusal support keep this anterior position of the condyle, unloading. Okay, no problem. It's very safe situation. But what happened in class 2 high angle cases, especially in class 2 cases, easily loss occlusal support because lack of vertical dimension, especially in the posterior part of the upper dentition of the 6 and 7. This make posterior occlusal plane inclination very steep and induce posterior adaptation of the mandible, um, making a lot of compression of the joint. And here you can see no space here, and the longitudinal axis of the condyle go like this, is bending like this. Okay, and this induce degenerate of the condyle, and finally osteoarthritis change of the condyle. Okay, a lot of compression, no occlusal support. This is the problem. The problem of the class 2 is not the dental class 2 relationship. The problem of the class 2 is the posterior position of the mandible, is the compression position of the condyle. Okay, please understand. Okay, this is the reason because you have to treat this type of patient in very early stage of growth and development, in order to prevent, in order to intercept this type of problem. Patient, 7 years old patient, Sammy, he complained flat out anterior teeth. This patient, somebody else start treatment with a functional appliance bionator. It's a class 2, division 1, but maybe he used bionator 1 year, but no improve, nothing, almost nothing. This is his situation at that time. Retrognatic mandible, very stiff posterior occlusal plane inclination, and tumor flat out anterior teeth. Yeah, something like this. A lot of anterior rotation of the maxillary arch. Okay, and cranial base angle very open. This is a class 2 high angle case. A lot of retrognatic mandibule, API 67 degree. Mandibular plane angle 33 degree. It means high angle case. Okay? This is a problem list of this case. Skeletal class 2 with large overjet and deep overbite, retrognatic mandible, upper frontal teeth, yeah, with labial inclination and over erupting. High angle case with lower facial height 53, too much increase, and mandibular plane angle 33 degree. Class 2 high angle case. So our treatment objectives are increase vertical dimensions, especially in the upper posterior area, upper 6. You have to make a plaque, increasing a flat of posterior occlusal plane, increasing posterior vertical dimension. Okay. After that, elimination of posterior discrepancy by lower third molar extraction, and then try to obtain the proper inclination of the anterior teeth. In this case, our THP position was 3 or 5 millimeters forward. Then decompression of the joint, and then try to get class 1 correction by articular compensation. Articular compensation is try to bring anterior the condyle anterior position. Okay, when you bring the condyle anterior, you are making some articular compensation at the joint. If you want to to make possible the articular compensation, you have to get very retrusive guidance in the premolar and very nice retrusive barrier in the first molar. Okay, and Professor Sato proposed try to make this overlay in D and E, and then try to imitate the morphology of the first premolar in the first deciduous molar, and in the second deciduous molar try to imitate the morphology of the first molar. Okay, and then try to induce to his mandible to the anterior position. Yeah, in this case, I made this type of overlay, but one of the main problems with this approach is that you have to look for a good technician. But in Colombia, yeah, it's not good. I couldn't find any technician that who can make this kind of WhatsApp. Okay, and somebody did this WhatsApp, but you can see the morphology here is not good. Yeah, and this morphology is not good, and the mandible couldn't stay forward position and easily go back. And in order to try to solve this problem, I put some acrylic here and induce this child to buy in forward position. And in this way, I keep in anterior position. But at that time, I want to make very nice WhatsApp and try to keep the mandible with this WhatsApp. Maybe 6 months later, in September, I organized one orthodontic course in Japan with some Colombian orthodontics. I brought all these orthodontics to the Kanagawa Dental University with Professor Sato. We took Colombia Marathon course in Japan, and I brought this case, yeah, to Japan in order for to make the WhatsApp. There was the situation of the child. Maybe 7 months later, I put the manual a little bit forward, and then I tried to remove the overlay and try to make a new overlay. Okay, and this was his situation in the right side, class 2, and the left side, class 1. Right now, his mandible is shifted to the right side. Okay, this is not good. Okay, a lot of anterior teeth, a lot of flat out, and I mounted the cast on the articulator. This is RP position. It's a full class 2 on the right side and class 1 in the it's a half class 2 in the left side. Okay, after mounting. So this is PRP position. Because this is our RP position, I need a new position. And we can get our new THP position on articulator. So I reposition the manual 5 millimeter forward in the right side and in the left side 3 millimeter forward. Okay? And in this position we made overlay. Okay? And we imitate D6. Yeah? Very nice contact, especially in the lingual side, also in the buccal side. And then I put this new overlay in his mouth. And also I need to correct this anterior position of his anterior teeth. I have to intrude and retrusion the anterior teeth, and in the molar I try to extrusion of the molar in order to increase vertical dimension and to flat posterior occlusal plane. Okay? And this is the situation after overlay, new overlay. Okay? And you can see here the occlusion in the posterior part. If you put some appliance 2x4 and try to make some tip-back bend in the posterior part, this induce an extrusion here and intrusion here. In order to do that, I use this double arch wire mechanics. Okay? And this double arch wire, this is the main arch, intrusion arch with tip-back bend, 45 degrees of tip-back bend in the posterior part. Okay? This produce molar extrusion and intrusion of the anterior incisor. But in this type of patient, you have to use another wire, a sectional wire for the anterior teeth, and we put here in the distal part of the temporal canine. Okay, here, and our objective is to apply the intrusion for here. Okay, little bit back of the center of the resistance that is here. This induce a moment that induce a retro position of the anterior incisor. Okay, so double arch wire is composed of a sectional arch. Usually you can make the sectional arc 16 by 22 stainless steel, or you can use gunmetal 18 by 22, and also you can make this intrusion arch stainless steel 16 by 16, or gunmetal. You can also use 18 by 22. If you use gunmetal, you have to just only make a tip back here, okay, of 45 degrees. With gunmetal, it's very simple. Okay. And then we have to apply the intrusion force here at the foot of the canine. If you make intrusion here, it's go a little bit far from center of the resistance. So you have here some distance, okay, and then you induce like this. This is the reason because the anterior incisor goes intrusion and a little bit back at the same time. Okay, I'm gonna show you how to make it a regular intrusion. Okay, you make a mark between 6 and 7. If you are using stainless steel, you have to make a loop in order to reduce the coefficient of deflection of the wire. Okay, you have to make some loop between 6 and 7, something like this. You bend. After that, you make 90 degrees down here. And after that, another 90 degree. And adjust it, just only adjust it. Sorry, I get out of the magic. Yeah, 90 degree again. And try to do, and then cut the wire here. You can use a thin plier. This is a twin plier. And then make another loop here between 5 and 6. Okay, you bend down and then lingually inside, a little bit inside. Then make this loop. And after that, bend down 90 degree. Okay, this. And then another 90 degree here. 90 degree here. Okay. And then cut the wire. And then you have to activate the wire 45 degree. Very simple. Okay. You have to little bit open because in order to prevent the too much lingual inclination of the 6. Here, 45 degree of activation. Here, it's a feedback activation. Okay, and this induces intrusion and retrusion in the anterior part of the tissue. Okay, if you use gunmetal, you have to. Yeah, it's very simple because it's more simple because you have to make just only here between 5 and 6 feedback. Okay, and also you have to make a sectional wire in the for the anterior incisor. Okay, distal to the canine, the temporal canine, or middle canine, and then make another mark between central incisor and another mark between central and lateral. Okay, in the canine mark, you make a 40, 90 degree bend here, and then try to make a loop over the edge of the wire. Okay, not over the flat part of the wire, over the edge, and you have to bend lingually, palatally. Okay, and then cut. And after that, you have to go to the another side and try to make the same bend. 90 degree over the flat part of the wire. Okay, 90 degree, and then over the edge of the wire, you have to make a hook. Yeah, this hook is not too high, just little. Okay, and like this, and then cut the wire. Okay, after that you have sectional, but you have after that you have to make some artistic bend. Artistic bend means that you hold the wire at first between central incisors. Central incisors. Okay? Yeah, you have to put very flat here. Between central incisor and then have to bend holding the wire in between central incisor and then make like this. Just little bend here. Okay? Not too much accentuated. And then between central and lateral, mesial part up and distal part down. Okay? This is an artistic thing. And in the another side, between central and lateral, mesial part up and distal down. Okay? Maybe it's too much. If it's too much accentuated, you have to reduce it. Okay? Okay. It's finished. Something like this. This is a sectional for the anterior incisor. Okay? This is a tip-back bend in the posterior part induce an intrusion force in the anterior teeth and extrusion force in the molar, something. And big moment over the molar, maybe some distalization of the upper, okay? And also the anterior incisor goes forward. This is the reason because you have to try to put the intrusion force here, not here. Because if you put the intrusion force here, more flat out. Okay? This is the reason I put the intrusion force here. And also in order that this wire go like this, not here, you have to bend a little bit distal to the lateral, a little bit down. Okay? And after that, this is 2 months later. Yeah. Intrusion, intrusion, here, changing anterior position of the anterior teeth. And you can see the situation. This was 3 months later. Extrusion of the molar here are intrusion and retrusion of the anterior teeth. This 5 months later, is you check the patient. You have to check the patient every month. And if you if the anterior position, if the anterior teeth is okay, you have to stop this mechanic. And if you want to some more extrusion in the molar, you have to use just only one wire. Yeah, intrusion wire, okay, like this. This is a 016 Australian wire, tip bend here, and I put this wire directly into the bracket slot, okay, in order to keep this anterior position, okay, of the incisor. This is very important to get very nice space here for anterior adaptation of the mandible. Okay, look at the midline position is okay. Mandibular position was corrected by anterior reposition of the mandible and put his mandible in the correct midline position. Okay. After that, I continue checking everything. More extrusion here, more change. and always have to check that everything is okay. And here the premolar start to direction. Yeah, if the mandible is forward, all these premolar induce to forward adaptation of the mandible to the very nice class 1 position. Okay, this is the situation after he exchange of the buccal segment, and you can see the change of the anterior incisor position. Mandible adapt forward and start changing, a lot of changing here. After reposition the mandible and after correct anterior position of the incisor, he start closing her mouth and start nose breathing. Okay, you can see after reposition the mandible forward. Yeah, straight profile, very nice. This prevent any osteoarthritic change at the condyle, any compression of the condyle. This is very good for his quality of life of this patient. Okay, this is a total change at the start of treatment and the sequence, and finally I got this result. Um, uh, how I am doing right now this procedure. I try to make it, I'm doing the same, but for me, very more easy way. Yeah, because I don't have any good technician in my country for to WhatsApp. And I have to do in a little different way. This is a patient, 11 years old patient, class 2 division 1, but maybe he's a more maxillofacial type of class 2. Yeah, class 2 division 1, a lot of flat out the anterior teeth, deep bite, not enough vertical dimension, something like this. This is a lingual view, class 2. I think this normal facial type, APDI decrease, 75 is I think class 2. ODI little bit increase, divide, lower facial height also decrease. Okay, we have to increase vertical dimension, reposition mandible forward. Yeah, in this case, I use very easy way. I put here some composite here, and then I mark this central midline, and then I ask to the patient to bite forward in forward position. After that, we created some contact between the composite and the this incisor, this molar here, in order to keep mandible forward position. After that, I use double arch wire in order to intrusion and retrusion at the same time of the anterior incisor and extrusion of the molar. Okay, something like that. You can see here I induce this contact of the lower ear and try to keep this position with this contact. After that, these molar are in this occlusion here, and I want to make some extrusion here and also here. This is the reason because I use here this wire, this and tip back here. Okay, and here intrusion and at the same time retrusion, because I'm applying the intrusion force here, okay, and also here. This is the system, the biomechanical action of this. And you can see extrusion here, and intrusion and retrusion at the same time. Okay, and 3 months later, after I got a very nice position of the anterior incisor, I removed the sectional arc. I use just only one arc here, just only one. But the difference is that this wire is directly into the bracket slope of the anterior teeth. Okay? In order to change the application of the intrusion force is more in the anterior part. Okay, here and here same extrusion. Okay, and after that, 3 months later, I put utility art. And utility art is very simple, and I finish the case. Hit mandible position, class one, good. And you can see 6 months later. This is very nice approach because you don't need the cooperation from the child. It's very simple, it's working all the time, no cooperation. Fish. And sometimes in the patient that who has a good inclination of the anterior incisor, you can use 2x4 utility arch and plus overlay. Okay, acrylic or composite overlay. Okay, this is also 11 years old patient, Sebastian, have a breathing problem. Also, this patient 2 years of treatment of functional appliance treatment. Okay, no improve. And again, in this patient, sorry, I put here composite here, again here, and then I ask him put his mandible forward position. Okay, this is the panel, mid dentition, big bite, class 2. Yeah, class 2, the tendency is low angle cage, big bite, some airways problem here. This is a buccal view, class 2. This is a lingual view. Deep bite, overreaction of the anterior teeth. I need some intrusion force. And posterior occlusal plane very stiff. You have to change, more flat, and then reposition the mandible forward. Okay, lower facial height decrease. This is the position of the condyle is the backward position. A lot of compression here. You have to eliminate this position. You have to unload the joint. If you unload the joint, this condyle start growing secondarily. Yeah. Okay. You can see here problem. And in this case, because the anterior inclinations of the anterior teeth were good, I decided to use this utility arch with tip bend of 54 degrees here. metal 18, 18 by 22 and tip back here of 45 degree. Okay, this induce um, intrusion force here, big moment in the molar, and extrusion force here. This is very important to increase vertical dimension in the posterior part of the dentition and also make flat posterior occlusal plane. Okay, this is a utility R bending. I use the Nance plier and use the second step in order to bend the anterior part between lateral and canine. Okay, I use the second part of the plier, bend like this, and then without reposition the plier, another bend distally. Okay, and then I mark in front of the 6. Here I use the second part, make a bend down and then posteriorly. Okay, and then cut the wire. You have to cut the wire. Okay, on another side, you have to try to do the same. Okay, and then cut the wire. And you have to enlarge a little bit the posterior part in order to prevent too much inclination of the molar to the lingual side. Okay, you have to expand a little bit, and then you have to put some tip-up bend in the posterior part. 45 degree tip-up bend. Okay, and also in the another side. Okay, in this case I use here gunmetal 18 by 24 by 22, 18 by 22 here, tip up bend here in order to in extrusion here and intrusion here. Yeah, I put here overlay, composite overlay here, and ask him to buy forward position here, and then I cure the composite here. And you can see the molar start increasing occlusal vertical dimension here and establish class 1 in the molar. Okay, this is very important. This is 4 months later. This is 5 months. He is right now 6 months of treatment. Yeah, this is the comparison before and 6 months later. Yeah, in 6 months, his mandible is in forward position, in class 1 position. More important, we unload the joint, we decompress the joint. This is the key point in this treatment. It's very easy treatment, very simple. You don't need any cooperation from the child. Okay? And this is the situation before and 6 months later. And if you increase here vertical dimension, yeah, also you can eliminate the crowding in the anterior part of the dentition, because the crowding is also a vertical problem, according with from South. Okay, I took this panel. This is his situation right now, and I recommended his mother to remove this lower third molar. Okay, I keep the upper, and this is his lateral ray, and you can compare before, and this is his situation right now. Mandible a little bit more forward position. Okay, and this is good. Also, early sign for in patient with degenerated TM joint disease is ECI, horizontal condyle angle ECI, ACI is a good indicator for degeneration of the joint. Also, when the condyle is displaced, one of the factors for this condyle displacement is ECI increase.
Không có bệnh nào hết hả?
ECI
Vậy mình làm ca 7 giờ đúng không?
Dạ, làm nguyên tối rồi đó.
Some paper have report, especially
Vậy là
Dr. Me from Washington University. He reported that larger horizontal condylar angle is associated with moderate to severe osteoarthritis change. Also, in a subsequent longitudinal study, he found that the clinical progression of the osteoarthritis preceded horizontal condylar angle increase. Okay, this is a very good indicator of osteoarthritis change at the condyle. Professor Sato, yeah, he started checking this angle, yeah, maybe more than 40 years ago. He used at the beginning 3D medical 3D CCT at that time. That medical was not really good. Maybe dental right now is so much better, but he start finding that especially in class 2 patients, this horizontal condylar angle increased so much. Also, I start checking this angle in class 2 open by case. For example, this case with a lot of osteoarthritis of the condyle increased so much here in both sides. You can see this is a
cứ mạng là trên chỗ phòng trực
flattening
nè.
of the condyle also here in the
Thì trong định danh với lại báo số lượng không, ở dưới đó có đang còn ca nào không?
Increases ACA here. And yeah, more than 40 years ago, professor was very interesting about the condyle morphology in the X-ray, because he wondered what happening in the condyle, because why this shape like this? This is a really flattening, or yeah, because at that time he checked in the panel and he noted that the increasing on the width of the condyle here, and also here two condyle. This is a lateral pole. This is a medial pole. Professor Sato called this double condyle in this patient who start developing increasing in the ACA. He did very simple test. He took a condyle from the dry skull, and then he took a strain different angulations. Here 0 degree, 10 degree, 20 degree, 30 degree, 40 degree, and 50 degree. And you can see that the morphology of the condyle staying same, but what happened is changing the X-ray morphology. It seems that the condyle is increasing these dimensions, but it's because the horizontal condylar angle are increasing. And here you can see, here this is a lateral pole, and here medial pole of the condyle. Here lateral, here medial. Okay. In 2017, I did a research about MLD malocclusion. Again, in patients with mandibular lateral deviation, usually the shifted side, the position of the condyle is more backward and a little bit medial position. This is the reason because this condyle have a lot of compression and osteoarthritis change. Especially in this side of the joint, the horizontal condylar angle increase so much. Yeah. This is the reason because we try to
alo, cho
make
nó
to do
trên phần
another
chụp lãnh đạo
research.
nè, cho anh lấy số
I
liệu
took
á, ở dưới đó
58
mình hôm nay
patients
chụp
and
lại
tried
lại
to
vậy.
compare shifted side to the
Ví dụ là thu
contralateral
hàng
side.
còn
And we try to compare horizontal condylar
rồi cho
angle
anh số
in this
liệu là hai
patient.
bên luôn.
Yeah. For
Đúng rồi.
example, in this, the mandible is shifted to the left
Quyết
side.
định 23
In this side, the horizontal condylar angle is larger than the contralateral side.
Bảo hiểm y tế
A
4
lot of
nhập viện 5.
osteoarthritis
Đúng rồi, nhập viện 5
arthritis
đúng rồi.
change here. Okay, we define the horizontal condylar angle as the angle between each mandibular condyle long axis from lateral
Lúc nãy em nói là hôm nay
and the
tiết 15
coronal
à,
reference
25.
plane in the axial view. Okay, and then we measure this angle. Okay, I published this research in the last June and the Angle Orthodontics Journal. Okay, and in this study we select many people as a control group. It was class 1 no MLD. In the class 1 no MLD group, the normal value of
trong ngày hôm nay đó
the
từ 7 giờ sáng đến giờ đó ha.
was 70.70,
12 triệu tròn luôn.
and this is the MLD group, 58 degree. Sorry, 58 subject. We divide and we check horizontal condylar angle in the shifted side and the contralateral side. And you can see here we got differences between no MLD group and shifted side group. Okay, in the shifted side group, horizontal condylar angle are larger than the no MLD group, and no difference between no MLD contralateral side group. Okay, almost same value. So also we divide this sample of 58 patients or people in two groups. One group, especially exactly 47 cases present differences between shifted side and contralateral side more than 3 degrees, and 11 cases that this difference between than 3 degrees. And in the different horizontal condylar group present is significant difference between shifted side and the contralateral side. And in the group with less than 3 degrees, no difference. Okay. These results indicated that the condyle on the shifted side in MLD cases has a large ACA, suggesting a strong tendency for morphological alterations in this condyle. Okay, and in all MLD group, class 1, class 2, and class 3, we found differences between shifted side and contralateral side. Okay, and why this ACA angle increase? Yeah, it's because in the shifted side, usually the condyle is displaced distally. Its lateral pole is supported by the strong lateral ligament that inhibit its distal displacement of the condyle. And alternately, the medial pole here lacking this strong ligamentous support is easily displaced backward, thus providing a rotational component of force here, okay, of the condyle on the condyle, which increases the horizontal condylar. Okay. Okay. Let's.
Hello anh chị bạn nào
I
nghe nè.
would like to show you this patient. This is a patient.
Tiếc cho anh là đọc lại là cái hôm nay bác sĩ trực cấp cứu là điện danh chính đấy.
She complained of pain of the left side of the joint.
Tường. Bác sĩ Mại Chú là bác sĩ Phú Quy. Bác sĩ Quý. Ủa sao anh thấy Tường trực đấy?
After 8 years, the left joint start pain continues all day. After that, somebody else did fourth premolar extraction treatment. After ortho treatment, the pain gone worse and headache start 2 or 3 times by week. Also start reducing maximum opening in 31 millimeters. She got some problem with muscle and also pain, especially in the left side of the joint, chronic pain here, shoulder. This was her situation before orthodontic treatment by premolar extraction. Not too much crowding. I don't know why this orthodontic did some extraction treatment in this patient. I received this patient at the 35 years old with pain here in the left side. All the dentition is too much backward position, retro inclined position. This is right now a very close dental arc, a lot of fencing here, and it's impossible for her the mandible go forward. And after that, the mandible start going backward position and start develop some osteoarthritic chain and also pain, especially in the left side of the joint. This is a reference position. The tendency is a class 2 with retronating mandible. In easy ICP position is almost same position. And this is the upper arch is very narrow arch. It's like a fencing here. No curves V, very flat, and especially posterior occlusal plane in the left side is steeper than the right side. Negative curve Wilson in the buccal segment, upper buccal segment in the premolar area. This is a Bruce checker in the 7 interferences here. This induce a problem here. Okay. Especially in the left side, the posterior vertical dimension at the 7 is shorter than the right side. Okay, all the guidance very stiff, especially in the right side. Posterior occlusal inclination is stiff in the left side and flat, little bit flat in the right side. Okay, it is a class 2. Retronative mandible, no intercoronal opening angle here in the anterior part, and you can see the condyle position is very back and medially positioned. Okay, this is a 3D view of her condyle. This is a coronal view, axial view, and sagittal view. Okay, osteoarthritic chain here, flat condyle here in the left side, and you can see in the left side the HCA is larger than the right side. Okay, this is a sagittal view. axial view, and this is a coronal view or ear condyle. This is a intraoral model 3D finding. Skeletal class 1, dental class 2 relation did overbite. Make a mistake, skeletal class 2. Okay? Flat
Mình ở bên
B, negative
chỗ
groove
nào phẫu thuật
Wilson,
trước hay là phẫu thuật ra
upper
ngoài?
and lower incisor
Đúng rồi, mình
retroclined.
Trong điểm danh hôm nay là ai?
Steep
Bác sĩ
upper
Tường chụp
frontal
là
diff guidance, narrow
bác sĩ
upper
Tường, bác sĩ Quý.
and lower arch,
Rồi.
posterior interferences, or first
Kỹ năng tìm ra
premolar and third molar
Em
are
Phương.
absent. ACA is larger in left side than
là
right
làm
side,
cấp cứu hả?
and this is a hair
Rồi.
condylograph. She showed delta Y shift. Delta Y shift is a transversal deviation of hair condyle in the symmetric movement like a protrusion, retrusion, and open and close. Okay? This is especially in the left side. Her mandible is a little bit shifted to the left side. This is the reason because she got some pain at the left side. And if the mandible is displaced to the left side, the condyle is displayed to the contralateral side. Okay? In the left side, the condyle a little bit more inside. This is because when she starts the protrusion, retrusion movement, the condyle moves a little bit lateral and then start. Okay? We call this movement delta Y. Okay, also increase Bennett angle and Bennett movement here. Here Bennett angle 8 degree, Bennett movement 1 millimeter outward and 3 forward at the same time. In the left side also same problem. Okay. And delta in open and close moving delta Y shape. This is the curve of rotation here and translation. The maximum rotation here was 21 degree. This is the reason because maximum open was decreased. Yeah, normal value of rotation is the 30 degree. Here compressions and praxis show a big shift to the right side here. This transversal movement in Brazil induce a lot of interferences in the posterior path of the dentition. Okay? In chewing moving here, in the frontal view, for any reason, the mandible avoid to go to the right side. Maybe the reason is because in the guidance of the upper right side is too steep. Okay. Okay. This is a condylographic finding. A lot of problem. RCP is a D-range reference position. So we establish a therapeutic position 3 millimeter forward and 1 millimeter to transversal side. Okay? And in this patient, I tried to anterior part of the dentition, enlarge the upper arch. I put some spleen, reposition spleen in forward position. After 3 weeks later, I start this style of treatment. I use Australian wire here with open coil here between 6 and 7 and between 6 and 3 to open and flare out this anterior teeth. Okay, try to open the fangs. Okay, and then try to reposition the mandible. After that, I put gum metal with tip-up bend, rough one. I open this anterior loop, first loop, in order to advance anterior teeth and then reposition the mandible. I use overlay over the 6 to reposition the mandible forward. After that, her pain at the left joint start reducing. Okay, I keep this position open, 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 and then I use this open coil here between central and canine to little bit canine little bit back, and this central incisor little bit forward, and close this gap here. And then I made some reconstruction with composite here in order to close this gap and keep this inclination. Okay, and in this position, she feels better without any symptom. And in this way, I reposition the mandible. And I right all the dentition, establish new occlusal support, and this is the reason because all her symptom has gone. Okay, this is the situation before and after, and this is before and after I open this cross checker. No con. Yeah, we are controlling here with the guidance here, anterior position of the mandible. And you can see here, I try to increase vertical dimensions in the left side. Okay, you compare here before and after. And I open all this guidance, and her mental position is okay right now. You can compare here before and after orthodontistry. Okay, I tried to make flat this posterior occlusal plane and try to reposition the mandible forward. Okay, you can see the correction and open here this intercoronal opening angle. Okay, now for the function of the mandible, this is before, this is after. Okay, got the inclination of the anterior teeth. And also increase airways. This is before and after. And look at the position, condylar position in the right side, especially here in the left side. Compare here, this is after, this is before. Yeah, it's clear. We reposition the mandible forward and establish new occlusal support. This is the reason because her pain has gone. Okay? And this is ACA angle decrease a little bit. And we are expecting some morphological change here by remodeling process. Okay? This is before, this is after. Now you can see this position change is more forward. This is the situation before and after. Okay? And right now she's so happy she can buy a hamburger. Yeah. No restrictions of the open movement. Before and after, she can open. Okay, quickly I'm gonna show you, this is my last case. Also, this patient got a lot of symptoms related with this dysfunction of the autonomic nervous system. Yeah, he got a Meniere syndrome, Meniere-like symptom like a vertigo, headache, posture problem, low hearing. Yeah, too many symptoms, especially too many medical symptoms. Yeah, he spent more than 10 years visiting different clinics, different hospitals in Bogota. And this is a list of from this medical clinical history. Yeah, oral fitness, vertigo, 5 years of evolution accompanied by nausea and vomit, tinnitus, retroarticular pain, headache. Yeah, many symptoms, many medications, but without any good result. Postural problem, also class 2, low angle case, divide. Okay, chronic pain here. Bruce checker a lot of interferences in the posterior part of the dentition. Yeah, here problem in the little bit delta Y shift to the left side, reduce his open and close movement, increase Bennett angle. When the Bennett angle is increased, this means the loose joint. Okay, a lot of compression. THP position in this patient 3 mm forward. Okay, this is a MRI. This is a open. Here is this closed position. This is anterior displacement in both sides and condyle backward position. When he opened his mouth, he reduced here the disc. The condyle reduced the disc. His displacement, this reduction in both sides. Okay? No occlusal support in the posterior part of the dentition. Small condyle, especially in the right side. Class 2 low angle case. Yeah, a lot of postural problem, especially mastoid is inclined here, temporal bone, affecting the axis and atlas also. Something like this. Postural problem, especially in the right side, very stiff posterior occlusal plane. Yeah, no support here. You can see his lower 7 in both sides are too much inclined lingually. No contact here. You can see it. This is the cause of the loss of posterior occlusal support. And this is the reason because a lot of compression on the joint here. Okay? ACI increase. And this is the position of his condyle. Backward position. And you can see no support here in the posterior part of the dentition. This starting point. I put some mulligan here between 4 and 5 to enlarge upper arch. In this way, make possible to mandible to forward position. This is after enlargement, the arch, and then I put 2 Australian wire and align this 7, okay, in this way. After that, I put some composite in the molar, reposition the mandible forward, hip back bend to upright all the dentition and use short class 3 elastic. Okay? In order to keep this anterior position of the incisor and to upright all the lower dentition. Okay? I start doing this and then I change to rough 2 in order to increase more vertical dimension in the upper and lower, and then try to establish retrusive guidance here in the premolar area. Okay? After that, after I reposition the mandible, or his symptoms start going. It's incredible. This is very nice. I enlarge upper arch and reposition the mandible using overlaying the molar and writing all the dentition, and after that increasing vertical dimension here in the premolar area. After that I put some elastic in the posterior part of the dentition in order to increase vertical dimension in the posterior molar area. Okay? After that I stabilize this new position. Okay? And then finish the case. This is 1 year, 5 months later. Class 1, reposition the mandible forward. Good inclination here. Good inter-opening angle here. Freedom, anterior freedom of the mandible. And try to upright all the dentition. Look at his condyle is more forward position. You compare here before and after. New occlusal support. This is very nice inclination. Okay, good for the anterior function of the mandible. The occlusion keep this anterior position. Yeah. API of is almost class 1. This is good. And reposition the mandible forward. Now, compare his posture right now. This is before, this is after. I change the temporal bone position as well. And also make flat posterior occlusal plane both sides. And reposition the mandible forward. And also increase airways. This is his situation after. This is before. And I try to get new occlusal support here. Compare, this is his situation before, this is after. Okay? I reposition the condyle forward. Before, after. Before, after. This is before, this is after. Before, after. Okay? Also, axial view. And this is sagittal view after. Both sides I reposition the mandible. This is the situation before, this is after in the right side. And this is in the left side, this is the situation before and after. It's clear. And this is the new support. This is before. This was before, this is after. Okay? This is good. I change everything. If you change mandibular position, you change all the craniofacial bone position. It's a very dynamic system that connecting each bone each other. Okay? Look at his position, new position, very correct position, no symptom. He's very happy right now. His quality of life increased so much. Orthodontic, we are very important person because we are the only people who can reposition the mandible, controlling vertical dimension, changing occlusal plane inclination. Okay? This is before, this is after. Okay. The orthodontic approach to the temporomandibular disorder patient, according with Professor Sato, are as follows. Eliminate posterior discrepancy, uprighting buccal segment, controlling vertical dimension, posterior vertical dimension, posterior occlusal plane inclination, then establish new occlusal support, reposition the mandible, unloading the joint. This is very important, and try to make R4 coordination, very nice R4 coordination. Try to get very nice interdigitation of all dentition and good guidance system. And after that, your orthodontic approach to the temporomandibular disorder patient will be successful. Thank you very much for your kind attention. Okay.